Perfect. All right. Excellent. Well, thanks for those that joined us tonight, and hopefully, if you get a chance to review this later, I'm Viet. I'm the current president of the Utah Academy of PAs, and this is a webinar that we have introduced during my tenure. It really is about industry relations, and so hopefully, as we move forward in time, we'll have more presentations from our industry partners where you learn more about disease state and therapeutic agents that are out there. But today I wanted to give a top takeaways from the 2025 Acute Coronary Syndrome Guidelines. It's often said, and we make stats up all the time, I think, whether it's in science, medicine, or just our lives. I'm sure John Baird, Dr. Baird can provide an anecdote or a quote from Yogi Berra about statistics. But here, it is notable that it takes a long time for guidelines to make it into practice. So I was hoping to give the top takeaways to move the speed up a little bit and make it chunk-sized or bite-sized, shall we say, with regards to acute coronary syndrome guidelines. And you may say to yourself, well, I'm primary care, or I'm rheumatology, or I'm nephrology. What should I know about acute coronary syndrome? And I would say we all have hearts. And coronary disease, or actually cardiovascular disease, so I'm going to include stroke and peripheral arterial disease, is the number one killer in the United States and globally, and its sequelae, if you should survive, is high, including the recurrence rate. So it's good to know, most of your patients will have, well, not most of your patients, but a majority of your patients will at least know someone, or you will know someone, or they themselves have experienced some type of cardiovascular event, in this case, acute coronary syndrome. So I'm going to give homage to the American Heart Association and the American College of Cardiology. You can see that American College of Emergency Physicians was also involved with this. The Society of Coronary Angiography and Interventions were part of this. So how do we manage patients with acute coronary syndrome? I will say that in 2023, we had a stable coronary artery disease guideline, and so you'll see some of that here. All right, I'm going to stop yapping on this intro slide here. But here are the citations. If you wanted to pull up the guidelines, they're available. We'll make sure that they are available to you if you are joining us later. So here are the writing committee members, and it takes some time. It takes some time to be on a writing committee. I've served on them, and just bravo. Bravo to the group for having put in the work, reviewed the literature, and critique any part of this that you want, but it takes time, and they did a great job of thinking through the acute coronary syndrome clinical trials, the data that are available, and have moved forward to create this document for us.
Yeah.
Yes.
Can you share your screen?
Oh, I am not sharing my screen. Well, interesting. I will do so. I apologize. Thank you, and I'm going to send a request here to share my screen, and okay, and now I'm going to share that. Well, thank you for listening to me talk for a little bit here, and now I should hope that we have moved into the sharing of the screen mode. So here it is, again, the intro slide for those of you that met it. I won't repeat everything that I just said, but the top takeaways from the 2025 Acute Coronary Syndrome Guidelines. And then as we move forward here, here's the citation, and of course it's recorded, so you I guess could take a screenshot, or we'll try to make sure the link is available for you. And then here the writing committee members. Again, it takes a village to put together these guidelines, and they had thank you for the staff actually from the American Heart Association, ACC, who really help put these things together for us. Okay, so acute coronary syndrome versus chronic stable. I kind of like pictures. I like the way that, visual stories, and it'll go all the way to the end slide where you'll see why this is important. But really, to get you into the moment, we could talk about acute coronary syndrome. I could talk about endothelial lining and how it ruptures, and you know these things, but our patients don't. So often I use analogies such as, traffic congestion. Here you've got an exit or an on-ramp, however you're going to view this. And unfortunately, traffic is a little bit congested, so it's moving slowly. It's not stopped yet, but imagine this. If you have this thoroughfare where blood flow is supposed to go through, but the lanes are getting smaller and smaller, and there's construction, people are moving through, but not very well. And you might experience that as some chest pain, chest discomfort, shortness of breath, nausea, all of that when you become ischemic. And then when you get to this end STEMI, where, boy, things are really starting to slow down, and maybe plaque has ruptured, and it's not just development of atherosclerosis itself to the end stage, but it ruptures as a young plaque or an old plaque, whatever. And then finally, we've all been here, where we've sat, on an interstate, there's been an accident, everyone's camping out, and nothing's moving. So you're not getting to your game, you're not getting to wherever, and you have items that need to be in the refrigerator. So not good news. Now, here is type 1 myocardial infarction. Just know that it goes from type 1 to type 5. And type 1 is your classic atherosclerotic plaque disruption. And this is what we envision. Of course, it's simplified here, but yes, this is what we're worried about is atherosclerosis that then ruptures, and you have platelet aggregation, and thus the requirement for antiplatelet therapy. And what do we do about this? How do you open it up? So as we kind of think through this, again, I'm thanking the ACC AHA for putting these together. I borrowed them, and so here, this is a non-occlusive thrombus. We always think, okay, what should we do first? And when someone shows up with risk factors and they're sweaty, diaphoretic, they've got chest pain, or from nose to navel, something's happening in between that nose area to that belly button, get an EKG. That's the first thing you should do. Now, NSTEMI, by definition, does not have ST elevation. And so there may be some features of ischemia. There may be some, non-specific changes. It's good to have a baseline EKG because these can be variations as well. But first of all is to get an EKG. You rule out STEMI, but they may have a biomarker such as troponin. Please don't use CK, CKMB, those are old, but here troponin, then this is an NST elevation MI, non-ST elevation MI. If it's biomarker negative and they have these symptoms that are very classic for obstruction, then you may say they're unstable angina, but it may also be non-cardiovascular chest pain, could be GERD, okay? Then, as we think of an occlusive thrombus, remember that traffic has just stopped. Here, you're starting to have electrical impact in this area where the heart has contracted, so that QRS, and then it is not able to repolarize well. There is infarction that's going on because of occlusion. And then they may also have elevated troponin. They do have elevated troponin. You're just not waiting for that in order to say, I've got to do something. So this is ST elevation MI. Now, the pre-hospital assessment is not really the takeaway here, but it's good to get us all on the same page. What do we do when there's suspected acute coronary syndrome? These are the chest pains or chest discomfort or diaphoresis, nose to navel symptoms that come in to your office, to the urgent care, to the emergency department. What are you going to do? And so again, first thing out of the gate, it's very easy. Is it STEMI? Is it not? Then, if it's not an ST elevation MI, you have a little bit of time to do other things. If it's not diagnostic for STEMI, it doesn't mean it's not an MI, but you might have to do other things such as biomarkers. Now, if it is a STEMI, easy peasy lemon squeezy. You're trying to get door to balloon. Within less than 90 minutes, right? Within 90 minutes of time. So here, in patients with STEMI, when you're managed with primary percutaneous coronary intervention, whether that's just balloon angioplasty or placing stents, for each 30-minute delay, you have a 7.5% increased percent of death within the first year. So even if you survive that event, that delay, we get you, we open it up, but we've had a 30-minute delay. That contributes to that next year, a higher prognosis of death. So door to balloon time is so important. Okay. So serial EKGs. You can detect potential ischemic changes if the first EKG was not diagnostic. You just continue on and you continue the serial ECGs. We have plenty of these actually. Over the last year, I've been in a clinical trial where we've been obtaining EKGs by a device, and a lot of these patients initially had a quote-unquote normal EKG, and then it went to STEMI. Okay, so here the types of acute myocardial infarction. Type 1 is really what we're thinking about with regards to acute coronary syndrome. Now there are other reasons why troponin bumps, but that is then type 2 and on. Okay, but here's a rupture or erosion of thrombosis. So let's get to the take-home messages. What to do, and there'll be 9 that the AHA and ACC put together. I have a 10th that I would bring up. It is important though to start somewhere. So we think about this, right? There's been a plaque rupture or erosion of plaque such that platelets start to aggregate, like you see here. Again, here's that coronary artery that ruptures, and then platelet aggregation. So what do? Well, that's aspirin. Right, we think about aspirin. It's like the original antiplatelet that we've used all this time. And the question's always been 81, 325, and we kind of answered that with the adaptable trial, where really it could be either. You just have less bleeding with 81 milligrams versus 325. But in an acute coronary syndrome, we use the 325 milligram at least for the first month. And then P2Y12 inhibitors. This is clopidogrel, this is prasugrel, this is ticagrelor. And we'll learn now in this new guideline, the update is what are the preferred P2Y12 inhibitors. And of course, then that leads to this idea of you should have dual inhibition of platelets. So dual antiplatelet therapy, or DAPT. Both an aspirin and a P2Y12 inhibitor. But the question down the line, so we've managed the acute coronary syndrome, or hopefully we have, and the patient survived. The question then will be later, after the first 12 months, where do we go, aspirin or P2Y12 alone? Okay, so as this is kind of busy. This is from the 2023 guideline for stable coronary disease. They spoke to both sides here of stable ischemic heart disease. If you do an elective procedure, someone has symptoms coming up, more angina, it's a little bit, maybe it's chronic, maybe it's stable angina, and then you decide to do something, and how you manage the antiplatelet therapy. Here, acute coronary syndrome then is what we're worried about, and we think of, if we're just going to do medical therapy versus lytics, because you're out greater than an hour and 20 minutes, or within that door to balloon time window of 90 minutes, you can get to a primary PCI center, and then there's bypass. But here, as we think of PCI, at least 12 months, you're going to be on clopidogrel, prasugrel, or ticagrelor, and aspirin therapy. So that's kind of the thought process, was it was DAPT for 12 months from the 2023 guidelines. And so now we're going to fast forward to the current. So in the US, we've been clopidogrel bound for the most part, and the European Society moved ahead of us, looking at ticagrelor and prasugrel. So that's it. This is the take-home message, is ticagrelor or prasugrel are the recommended and preferred P2Y12 inhibitors, unless they're unavailable. I would say cost makes it unavailable, but cannot be tolerated or are contraindicated. So ticagrelor, there's this dyspnea that can be associated, this shortness of breath, just because its mechanism, it doesn't happen in everyone, but it can happen. And then contraindicated, I put down below, prasugrel, you don't use that medication when there's a history of stroke or TIA, because then you have complications and bleed. So in patients with non-ST elevation MI, if they're being scheduled for an invasive strategy, so just so you know, STEMIs, that's an easy question. You go right to the cath lab. But NSTEMI doesn't always get to the cath lab early or urgent. unless there are symptoms like ongoing pain, they like diaphoretic, there's nothing's controlling it. You go to the cath lab. But there are folks that will kind of sit for greater than 24 hours as you kind of manage them and see what happens next before you go to angiography. And some are just medically managed; they don't go to angiography. So, anyways, in those people, go ahead and start upstream clopidogrel or ticagrelor. And that's not going to be a decision you're going to make. That's essentially the hospital team. But for those of you that are practicing cardiology, maybe inpatient, that's something to think about. Here again, aspirin, or 81 or 325 with a P2Y12, single agent. One or the other. I don't mean to confuse this because I'm going acute coronary syndrome, then past the 12 months into stable long-term management. But something to think about is that the guidelines are still geared towards 81 milligrams monotherapy after the first 12 months. But there's a lot of data saying maybe a P2Y12 inhibitor instead going forward for people with stable coronary disease. So here, number 2, dual antiplatelet therapy. So aspirin and P2Y12 is indicated for 12 months as a default strategy in people who are low risk of bleeding. So that's kind of easy for most of us to think, okay, they're going to be on dual antiplatelet therapy for the most part for most people, unless then there's some high risk and then we make some changes. So in patients that are at risk for gastrointestinal bleeding, go ahead and get a PPI in there, proton pump inhibitor. That's fine to use and it's recommended. B, for those patients who have tolerated dual antiplatelet therapy and they were ticagrelor and aspirin, after the first month, you can just go to ticagrelor. So you'll reduce bleeding, but also continue protecting that person from stent thrombosis and other MI that may occur afterwards. Okay, so that's nice. It's mostly dual antiplatelet for everyone, but for people who are tolerating ticagrelor and doing well, no bleeds, whatever, you can stop the aspirin after that first month. So that's why some of your patients, when you receive them, you're like, why aren't they on DAPT? And only on ticagrelor. This is the reason. Patients who require long-term anticoagulation, so let's just say they have atrial fibrillation, then really you can do, the apixaban, rivaroxaban, whatever, what have you in terms of the direct oral anticoagulants with a P2Y12, and then you can, all three, by the way, aspirin, P2Y12, and the anticoagulant for the first month, and then you can drop the aspirin after that month and just move forward with the P2Y12. In this case, they prefer clopidogrel because it doesn't cause as much bleeding as the other two. So this is kind of in a glance, I'm saying words at you, and these are medications that you may or may not be used to or ever prescribed, and cardiology may be managing them. And I would say lean into that feeling. It's uncomfortable when someone's speaking to you as if you should know. This is how our patients feel, man. Like if they've never had an acute coronary syndrome, never had a heart attack, and you're like, okay, we're going to be on clopidogrel, you're going to be on aspirin, you're going to be on statin, you're going to be on da-da-da-da, and then like for the rest of your life. And you're like, what just happened? That's what a patient feels like. So I just, please lean into that and say, if you're feeling a little stressed with what I'm talking about, just imagine how the patient feels, and they're just like, oh my gosh, I just survived a heart attack. And then like all these meds. So please navigate this for them and help them understand. So here, acute coronary syndrome, when you're selecting for P2Y12 and in what situations, you don't have to memorize these. This is here, but I just want you to know that it can get complicated. But for the most part, folks are going to be on aspirin plus ticagrelor or prasugrel. I mean, that's kind of be most folks. And then you're going to do some kind of other changes if they're tolerating ticagrelor, then you can stop that. But if they happen to, be on an anticoagulant, then it changes things again. Okay, so that was this part. What about atrial fibrillation or other reason for chronic anticoagulation? And I'm leveraging both the 2023 stable disease guidelines and this new 2025, which is here. If you have no indication for oral anticoagulant, you're just going to do everything like normal, like we just said. Really, aspirin for those that are just medically managed. Those with prior acute coronary syndrome, no PCI, then it's dual antiplatelet. Here, dual antiplatelet when they get a stent. Here, you're just going to drop off some of these therapies when they're high risk. But when it's an oral anticoagulant, then you're going to be on all three for that first month, and then drop aspirin and be on direct oral anticoagulant and clopidogrel for the first 6 months. And then after 6 months, you're just going to be on that DOAC alone. For those really high bleed folks, no PCI, just anticoagulant. Okay, so that's really how it kind of falls out right here, is 3 months, 6 months, 12 months. This is 2023 guideline, and it doesn't change much as we get to 2025. Essentially kind of stays within this realm here of DOAC and clopidogrel. So that's, when you get your patient from cardiology, they're like, I had a heart attack, this is what I'm on. This is kind of to help you understand like why they're on just DOAC and P2Y12 after that first month, if they follow up with you, or if they end up just on a DOAC alone. You're like, didn't you just have a heart attack? And then you look in there, oh, they didn't stent you, they're medically managing, you have AFib already, so they're just going to keep you on DOAC. Okay, so here are the strategies again with regards to bleeding reduction. If they're high risk for bleeding, you can see orange is 2A. So green is always like class 1 recommendation. Yeah, this is how we recommend in most everyone. And then you start to say, well, then if they're high bleed, this is how we change it. Okay, so these will be available as you come back to it. I think the most important thing is to recognize that not everyone will always be on aspirin and clopidogrel. Now you're going to see ticagrelor and prasugrel more often, and you might just see someone with ticagrelor alone after a stent. So these are the things that I think you just need to be aware of when you have these patients come to you. If you're not in cardiology, you may not be making those adjustments, but it's important for you to understand why those adjustments are being made or what's happening when patients come to you and they're not on an aspirin but just a P2Y12. So my favorite part, because I'm a lipid specialist, I love high-intensity statin therapy. It's recommended in all patients. But honestly, I've moved towards moderate intensity and ezetimibe. But it is important that their guidelines say high-intensity statin. And what they really mean is we want a 50% or more reduction in their baseline LDL cholesterol. And that's typically what high-intensity statin is. But they say, hey, you have the option of doing both a statin and ezetimibe just out of the gate. Don't have this medical inertia and treatment inertia. You can start those early. I love the call out here for non-statins. I've become quite familiar with bempedoic acid, which really just go to the Clear Outcomes trial. It's fantastic for folks that really have statin intolerance. Great medication, and it actually comes in combination with ezetimibe. So you get about a 45% reduction in LDL cholesterol in that combo therapy. So instead of taking 2 pills, they're in 1, and that's been fantastic. Of course, ivolocumab. Of course, it's one or the other, ivolocumab or alirocumab, and now this other newcomer, inclisiran, which is every 6 months. But there's not yet a cardiovascular outcome trial to tell us lowering LDL by using inclisiran is as effective as these two in terms of PCSK9. Certainly, we know bempedoic acid reduces events, and so do ezetimibe. I would say pound for pound, LDL cholesterol lowering for LDL cholesterol lowering, bempedoic acid is very in line with what statins do in terms of risk reduction for LDL cholesterol lowering. But I love here, they're calling out again, greater than 70, do a non-statin. If it's under 70, then really think about this, because there's this other threshold that you can think about. If they're still sitting above 55 and they're high risk, then you'll want to push them below 70 and below 55. So we can talk about that in a different time frame. But this is essentially it, right? Get a freaking baseline lipid profile. It doesn't happen often. I would say you'll be surprised. It's moved up quite a bit, actually, at my home center, yes. But it used to be around 30 to 40% of people would get a baseline lipid profile in hospital. Now it's closer to 80+%. But really, it comes down to this. Okay, if you've already started statin, really get your goals straight. Make sure that you're adding non-statin therapy to get them down. It's not easy to get to less than 55 without adding something else. But many patients, if you just added ezetimibe, they will get close, and probably you'll need another non-statin. Okay, so these are the folks that I think here it's easy. You just, add statin, add non-statin. Here you're like, ooh, should I add something? And I'd say yes, go ahead and do it, because a lot of these are really well tolerated, and you still get risk reduction as you head down in LDL cholesterol lowering. So here, again, these are the recommendations. I'm not going to belabor this, but take a screenshot or come back to it. These are the great recommendations here to A2B. And please, please, please think of these non-statin therapies. And we can talk about how to deploy them in some other time. Here, it's nice to know high-intensity therapy for statins. The reason why they're called high-intensity is because typically they lower cholesterol by 50% or more. And that's what the goal is a 50% reduction from baseline. And then you get to your thresholds. Okay. I like this slide because it talks about each of these non-statins and what how much more they contribute to lowering. It's so fantastic. If you look at the Fourier and Odyssey trials, if you have a 50% reduction and then you add 60% reduction, it's not like they go negative, but they achieved an LDL cholesterol of 29 milligrams per deciliter. Yes, it's safe. Well, that's a different conversation, but if you have that question, we can talk about it. Here for STEMI elevation, non-ST segment. I'm like, sorry, it's weird to say it this way. Non-ST segment elevation, acute coronary syndrome. So an invasive approach. That's really what we want is immediate or high risk or intermediate or high risk folks. You want to just go right to an invasive approach with the intent to revascularize. You're like, no duh, but there is some question as to who this makes the most sense. Otherwise, routine invasive or selective approach is good to identify what's going on, but you don't always revascularize these individuals. So this is kind of the choice in timing here. Unstable, very high-risk people go straight to an invasive strategy. For those that are high risk, routine invasive, you may or may not do any revascularization in those individuals. These intermediate folks, again, you're going to take a peek, but you may or may not do any PCI or revascularization. And then these low-risk individuals, still invasive approach, but you may still just medically manage because they didn't have a full blockage. You heparinized them, you did other things, and it may have gotten rid of the blockage. And so that's why they don't often, I shouldn't say they don't often, but not always get angiography in the sense of stent or balloon angioplasty or bypass. Here, if you're not familiar with this, we used to do femoral approach all the time. That's the puncture approach was down in the femoral artery, and now it is recommended to do a radial approach through the hand, wrist, and then adding intravascular imaging, which we didn't do, and a lot of places still don't do often, but it would be intravascular ultrasound or optical coherence tomography. This is what the radial approach looks like. Is you're coming through, usually this is kind of left approach, or actually right hand approach. So you can kind of see where they're puncturing rather than in the femoral artery. Here they're in the radial, and then you can see with imaging using these IVUS or OCT to be able to view. Really, they're beautiful pictures actually, and so the reason why they do this is to make sure they approximate that stent and deploy it fully and don't leave anything behind in terms of lesion that's not fully opened up. So 6, strategy of complete revascularization. You're like, what does that mean? Don't you want to revascularize completely? Like, don't just half deploy that stent. Yeah, so there can be more than one artery that is plugged up. right? So there's the culprit lesion, the like left anterior descending may have that clot, and so you're like, oh crap, you know, the STEMI all showed in that anterior V1, V2, or I'm sorry, V2, V3, and 4, and you're like, whoa, that's LAD. And so you go in there, but then because you've looked at right coronary artery and left circumflex, you're like, whoa, there's like 80% lesions in there. And so the approach is, yes, take care of LAD, and then if you can, take care of those others as well, or you can bring them back in a month or two and stage the PCI. That's what it means here later. So you might not do it all at once, but do it in stages. For these individuals. So here's STEMI with multivessel coronary disease. If they're in cardiogenic shock, you know, we don't really, the recommendation is like do the culprit lesion, but don't mess with anything else because they're probably going to crump on the table. You might have to do something else for them. Don't be messing around adding contrast, etc. Get the first lesion open, and then you can come back later to open up the other stuff. When they're hemodynamically stable, you have time, you're thinking about it, do the, you know, open up the first area, and then you can do bypass as well. So you can do a hybrid procedure of bypass after balloon angioplasty, or, you know, if it's low complexity multivascular disease, then just stents will do. That's fine too. And you can bring them back later to do further stents rather than do it all on the first admission in the hospital. And STEMI is the same thing. This is just, you know, culprit, non-culprit lesions and culprit lesions. That's all it means, is the one that's causing the most problems. You're going to treat that and then come back and do the others, either in the same, if they're stable, or come back and stage it. 7. So here, you're probably not going to deal with this. This is the microaxial flow pump, and Impella is the brand name, but here, you know, they place it for cardiogenic shock, and just so you know that this is happening, not that you're going to be doing it. The other thing that you may have learned that's, you know, axiomatic is, you know, adding packed red blood cells or transfusion, etc. When do you do it? Some waited till it was 8, some waited until it was 7. Here, the transfusion recommendations at 10 to keep it above 10 or higher, and so transfusing early to provide proper oxygenation and blood perfusion to those areas. 9, focus on secondary prevention, which is fundamental. So fasting lipid panel is recommended 4 to 8 weeks after discharge. If you've started statins, you don't want inertia. You want to see, did it do what we wanted it to do, which was lower LDL cholesterol. So please follow up quickly. None of this like 12 weeks later, not, you know, 3 months. You are going to forget. The patient's going to forget. So do this quickly. We have the earlier phase 1, phase 2 trials across all of these statin, non-statin therapies that show reduction is captured as early as 3 to 4 weeks. So there's no reason to wait 12 weeks for this. Okay, cardiac rehab. So this is it. I mean, I came out of cardiac rehab while I was in PA school. I you know, bachelor's in exercise science. I did cardiac therapy during my 2 years as in PA school, and it was fantastic. It was so fun to be able to meet patients, teach them, and talk to them. But these are the core components. We're doing all of this as cardiac therapists. So please, if you get a patient that comes to you after an MI and no one's ordered cardiac rehab, get on that, please. It's like return to injury. I mean, athletic trainers know this. Athletes don't just get back on the field. You have to rehab them. And so patients don't just get back to work, don't get back to family life, don't get back to life without some type of rehabilitation to help them navigate, because the anxiety is real with regards to having another event. Here, post-ACS discharge planning, so important. Referral cardiac rehab, all of these they're taken care of. So you can have a center-based cardiac rehab. I love that they've talked about home-based cardiac rehab. Not everyone can make it to cardiac rehab. It can be 30 miles away. It can be $40 copay and no one to take them. So having home-based cardiac rehab is so important as an option, and I'm glad they mentioned that. Viet's number 10. You've made it. Kind of a little bit over, sorry. So we'll have some question and answers here. But remember to keep care patient centered and focused. Back to my number 1. If this is the first time, this is the second time, third time. Look, it's scary. The patients need to know, their families need to know. Make sure that you're talking about acute event, the procedures, therapies delivered, the acute long-term prognosis, contemporary understanding of risk-reducing activities and therapies. So here it is, the post-discharge follow-up symptom systems of care coordination, and then whoops, I guess I copied a link onto there. But these are the things, okay, and I'll remove that later. I wanted to show you this because this is what I've been working on for the last 12 years. It's been available and they've updated it. This is the CardioSmart, and it is actually available to you online. So that link down below is essentially this. This is the life. You can click on all of these, and you can have your patient see the heart attack here. I like to teach them about their heart attack and say, hey, this is where your right coronary artery was occluded at 90%. You had a quote-unquote widowmaker. Please don't use that term. But at the proximal LAD, and there was something here. And so we had to, the left internal mammary was here, and then it skipped down. And then they did a saphenous vein graft here, down to that. So it's so cool, and to be able to teach patients and interact with them. There's so much on here, by the way. It's fantastic. There's arrhythmias in here. There's valve disease. So please feel free to download this. It's web-based here, but it's on iOS. It's on Google Play. And you can just teach them while you're there. You can teach your staff. You can have your staff learn about heart disease. So I'm going to turn it over. John, was there questions or thoughts or anything like that?
Yeah, no questions in the chat. If anybody would like to unmute yourself and be able to ask a question, now is a great time to do so.
Hey, Viet, I have a question for you, Alex here.
Yes. Hi, Alex.
Great job, by the way.
Thank you.
So what is the hardest part about home cardiac rehab to get the patients to do, at home? What's the hardest part about that?
You mean like referring or getting them? So the main thing. Oh, sorry. Go ahead, Alex. Go ahead and clarify.
Well, just the things that they do on their own at home. Is there one sticky point that's just like this one is the hardest for them to do for cardiac rehab when it's home centered?
Yeah. So what I would say is this is and I'm gonna leverage our athletic training experience here. John's also an athletic. Well, I'm former because I never recertified. But one of the things that you don't, if someone like broke their leg and you're like, okay, it healed, go. And they're coming back, they've got muscle wasting, they're not as strong, and they injure themselves again. And the thing is cardiac rehab is a really structured format in all of these things. You're teaching them how, and some of them have never exercised, by the way, or not formally exercised. Some of them just have never approached nutrition, etc. So that's why we bring them into a formal cardiac rehab center. But what I mean by home-based, because we give them exercises and things to do to take home, but what home-based is they never make it into a brick and mortar place. They're actually virtual programs that are available, and your health system may have a virtual program where they deliver that and allow the patient to participate cardiac rehab from their home. So that's what home-based is, really. Otherwise, yeah, they're at home and they're hopefully doing the things that you taught them at cardiac rehab, but that's like homework. Here, it's actual structured home cardiac rehab, either by virtual means or someone going to their house and delivering that care there. Did that answer things, Alex?
Yeah, that helps. Thank you.
Okay.
Other questions? Perhaps while somebody's...
Hi, Viet. This is Deepti. I have a question.
Yes.
Hi. Great presentation. Thank you. I have a question. How long would you recommend waiting? Say a patient, I started on ticagrelor and they start developing diarrhea, and it's just the first week of starting. And would you recommend switching them back to clopidogrel, or would you give like a loperamide or an antidiarrheal? How long can you wait before you make the switch?
No, I mean, I think that's an important question because first you have to think mechanism wise. Is it, I mean, especially in the acute setting or subacute setting, there are all sorts of things going on for patients. And I would hesitate to make a medication switch because most of them have just started like 5 new meds. So which one is it? And is it really ticagrelor? And I'm not sure that it is. Usually, what they get is dyspnea with ticagrelor, but there are these other idiopathic things that can occur. And I would say this is the time to ask, like, what's going on? Why are you having diarrhea? And they could just like have a GI bug actually. So I would be very careful about making a medication change until you've at least chased down and feel comfortable that it may be the ticagrelor and not the other 4 or 5 meds that have been started, or that they don't have other mildly infectious, whether it's viral or otherwise, thing going on. So after I kind of sort that out, I would say if it seems like it's persistent, and by the way, make sure they're hydrated and all the things that you'd normally do for diarrhea. Loperamide, I'm a little hesitant using that unless I know if I understand what's going on with regards to the diarrhea. I know that's not satisfactory as an answer, but I do think that first things first is to figure out what that is and what may be causing that before making the change. Having said that, if it does seem like it's the medication, if after a week that's what's going on and I've ruled out everything else, then that's in the first 30 days, that makes it a little bit harder if they haven't had a stroke or mini stroke, then prasugrel is the preferred next one to use. And then if they happen to have a history of stroke, then yeah, you're going to go to clopidogrel with the aspirin.
Thank you very much.
Yeah, great. Man, that's a great question. That's one of the things that we all struggle with to help our patients is what's a side effect that is consistent with the mechanism of the drug versus just something else going on. And I chase this down a lot with statin intolerance patients. We really kind of delve into it and make sure that it's either true complete intolerance, it's partial intolerance, or it's something else that's going on. And often those patients have like multiple other quote unquote allergies or intolerances, and so it takes a little time to work through all of that.
Thank you very much.
Yeah. Other thoughts or questions from thank you, by the way, for joining us. I know it's never easy to come on after a clinic and all of that to hear me talk of all people. But in any case, I'm grateful that you've joined us and hopefully that was helpful, at least as a kind of introduction to a pretty girthy guideline set. There's a lot of stuff in there. And you can come back to and learn quite a bit more. But those were my takeaways. John, any other thoughts or comments that came up out of the chat?
No, just kudos and someone wanting to know if we recorded this, and I can just tell everyone, yes, we did. And as we are able, we will make sure that is available through our website.
Excellent. Thank you, everyone.